Center for Tourette Syndrome and Associated Disorders, NJCTS, and its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate for any treatment. You are responsible for your own medical decisions. Now, I'm going to turn over the introductions of our speaker to Martha Butterfield, the webinar coordinator of NJCTS. Marty?
Thanks, Kelly, and good evening, everyone, and welcome to tonight's webinar on game-based CBT. Before I introduce tonight's presenter, I would like to call your attention to the slide on your screen about our new live chat program called Ask the Greats that we are introducing next Wednesday, May 24th at 7:30 p.m. Eastern Time. This new offering from NJCTS is for teens and young adults with TS. It's a different format from our usual programming, as there will be a video chat during which a moderator will lead a group of panelists in discussing a particular topic. The topic for next week's program will be disclosure, and the panelists will share their experiences in disclosing their TS to friends, teachers, strangers, and others. Before and during the programming, viewers can submit questions to the panelists for their answers. Ask the Greats sessions will be held every other month, with panelists sharing personal experiences and tips while answering questions submitted by viewers. If you have a teen or young adult with TS, please tell them about this. It's a great program and they can register at our website. Now to the introduction of tonight's presenter, Dr. Justin Misurell. Dr. Misurell received his undergrad degree from Rutgers University in New Jersey and his graduate degree from Fordham University in New York. He is the clinical director in the New Jersey office of the New York University Child Study Center, where he is a recognized expert on the evaluation and treatment of child and adolescent behavior disorders. He co-developed game-based cognitive behavioral therapy, which is an integrative and trans-diagnostic approach for addressing childhood trauma. Dr. Misurell has trained and supervised doctoral and master's level clinicians in implementing this technique. His work has demonstrated how game-based CBT can be modified and successfully applied in various settings with different populations. He is a licensed psychologist in New York and New Jersey and is credentialed by the Council for the National Register of Health Service Providers in Psychology. Dr. Misurell, welcome to our Wednesday webinar series. I'm pleased you're here and happy to turn tonight's webinar over to you.
Okay, well, thank you very much for having me. Thank you to everyone at NJCTS for inviting me to discuss the topic of game-based CBT. I'm very happy to do so and to bring wider attention to the model. Just to speak about the overview of the presentation this evening, the beginning of this presentation will focus on the background and rationale of the game-based CBT approach, and I will discuss the foundations of the model of cognitive behavioral therapy and the integration with structured play therapy and how that led to the formation of game-based CBT. I'll also speak a little bit about how this model, which initially was developed with child sexual abuse and trauma populations, whereas it has since been evolved and applied to children and families that are encountering a whole wide variety of different difficulties, from anxiety disorders to disruptive behavior disorders such as oppositional defiant disorder, ADHD, as well as children suffering with tic disorders and compulsive habit disorders. So we're going to get into all of that. At the end of the last third of the presentation, I'm going to give you some actual concrete game examples so that I'm not just speaking in the abstract. You know, what is what are the games of game-based CBT. I'm actually going to give you a handful of those examples, and I'm going to try to walk you through it. It's a little bit difficult doing it in the format of a webinar. Usually I have people in front of me where I can demonstrate the games. I could have volunteers to do so, but I'm going to do my very best to verbally describe how these games look and to walk you through, whether you're a clinician or a parent or a family member of someone dealing with a behavioral disorder, how these games actually work. Okay. So the first question that I like to pose is, well, what is evidence-based practice and why does it matter? And this is important. Essentially, the take-home is that evidence-based practice in mental health matters because this is the guidelines in which we are able to determine what is actually effective practice versus what is not so helpful or ineffective practice. And essentially, evidence-based practice means that we are integrating the available evidence and research expertise to guide and to determine what actions we're taking therapeutically. And this is very important with game-based CBT because everything that we do, we really try to make sure that it is anchored in an evidence base. Some pointers just to keep in mind about evidence-based practice for child mental health. There's been a lot of research in child mental health and looking into what's helpful for kids who are dealing with a variety of symptoms and behavioral problems. And just to summarize what's out there in general, effective treatments tend to be structured. Many of them are time limited, meaning that children do not need to be in treatment for, beyond 6 months, 12 months, although there certainly are kids who have chronic conditions where that's necessary. And we also know that a lot of the evidence-based practices that are out there for children with mental health difficulties are found within the behavioral and cognitive behavioral therapies. Sometimes cognitive behavioral therapy, or CBT, is confused as a synonym or as being synonymous with evidence-based practice. And just to clarify that, CBT is an evidence-based practice for a variety of difficulties, but it doesn't encompass all that is considered evidence-based that is out there. But for the purposes of tonight, it's certainly the model in which we are operating within. It is the theoretical orientation, meaning like the way we as CBT clinicians are viewing these cases. And I will speak more specifically about CBT in a couple slides. Another important point to keep in mind when we're talking about evidence-based practice for childhood disorders, caregiver involvement is crucial because the more that caregivers are involved, the more that caregivers or parents know what's happening in the therapy session, the more techniques and strategies that they can use at home, the better the outcomes will be. We know this through research, we know this clinically, through our own professional experience, so I can't emphasize that enough. I can imagine that the folks at home who are listening to this, who, if you are a parent of someone who is struggling with a behavioral disorder, the fact that you're on this webinar shows that you're probably very active and very interested in getting involved in your child's treatment, and I applaud you for that because we need to be good advocates for our kids, and in fact the research bears out that outcomes are better when that's the case. I personally someone more suspicious when children, especially younger children, are going into therapy and there's really no interaction with the parent. It's just one-on-one. Once in a while that's okay, but overall we really need parents to be partners with us in the therapy process. So cognitive behavioral therapy is an empirically supported treatment, as mentioned before, for a variety of disorders. I have a list here of very common and some not so common behavioral disorders in children, and there's been specific CBT behavioral manuals and treatment models that have been developed for these various disorders. So it's a very well researched and very well supported approach. Now, within the family of CBT, there are many different components, or to use another metaphor, within the tree, the family tree of CBT, there are many different branches. So some CBT branches are developed to treat selective mutism or OCD. Some are developed to treat ADHD and anxiety. But when you look across the different branches of CBT, you will see that there are key components that are in common, and these, in my opinion, are the ones that I have on this particular slide. So every CBT, every good CBT has a healthy dose of psychoeducation. What psychoeducation means is that we're providing the caregivers, the parents, as well as the children and adolescents dealing with the behavioral disorder or the mental health disorder, we're providing education and information about their condition. Just like if you were someone who was afflicted with diabetes or a heart condition, would want to know a lot about that disorder, you may go home and read up on WebMD, or you might look up Wikipedia, or do these other things that may be helpful or not so helpful, but you're an advocate for your medical health and there's something wrong with you. Well, in the same sense, we really advocate that people learn about their disorders when they're talking about their mental health, and we try to do that in CBT, providing a lot of information. So be it anxiety or ADHD, one of the very helpful things that psychoeducation does is it communicates to children and families dealing with these difficulties that they're not alone, that this is a condition that has been seen before in the field by other professionals, and that there are specific things that they could do to get help. And that in itself is incredibly healing and hopeful for families. Another thing that CBT does is provide emotional expression skills to children and families. In order to work through the various difficulties that children are having, we need them to work on expressing those emotions effectively. A lot of times kids, if they're dealing with something in their life, be it like a parental breakup or anxiety related to school, they may not vocalize or verbalize exactly what's going on. They may express their anger through hostility or aggression. We want to work with them to express those emotions more effectively using their words, using their emotional vocabulary. So you see this across the different CBTs that are out there. Coping skills are, simply put, things we do that make us feel better and that are good for us. And I say that are good for us specifically because there are plenty of things that we do to make ourselves feel better that are not good for us as adults, say eating junk food or drinking too much or smoking too much cigarettes or whatever it is. That could be an unhelpful and unhealthy coping strategy dealing with stress or anxiety or depression. These are coping skills that we talk about in CBT that are helpful and that are healthy, things that make us feel better and that are good for us. So these are some things that every CBT absolutely does, whether you're struggling with tics, whether you're dealing with anxiety or dealing with ADHD. If you're in CBT, you're going to be learning and teaching your child as well as yourself how to emotionally regulate and how to cope with difficult circumstances and distress. Now, exposure therapy, which is something that is more specific to the anxiety disorders and the compulsive habit disorders like OCD, exposure therapy, simply put, is having the individual who's experiencing the distress progressively facing the things that trigger their anxiety, and to do it in greater and greater increments. It's also known as systematic desensitization, and it's a methodical procedure that you do in cognitive behavioral therapy for many different disorders. Not all, but certainly the anxiety disorders and the compulsive habit disorders. And then lastly, parent training is a key component. As I mentioned at the earlier slide, any good CBT is going to have a healthy involvement with parents, unless it's contraindicated because of parental abuse or some kind of toxic relationship. With the exception of those situations, parent involvement is really critical. Play therapy. Now, I mentioned play therapy here because play therapy becomes, as we will see, a key piece of the game-based CBT model. Now, play therapy is a very varied field, and within the field of mental health, there are practitioners that are doing play therapy from different theoretical orientations, and not to get into too much jargony stuff here, you can be doing play therapy through a CBT lens or from, say, a psychodynamic lens, but play therapy is really, there's no one particular central authority of play therapy. There's like many variations of it out there. But in general, what play therapy really harnesses is that this is children's natural mode of communication. Every child across cultures, they understand play. You don't even need to speak their language. You pick up a ball, they understand what you're trying to do with it. Everyone understands games because everybody plays games. It's found in every culture. Play therapy is fun and engaging. And when you're doing treatment with kids, they're not going to just sit on the couch and talk to you for 45 minutes. You need to engage with them. You need to play with them. You need to mix it up a little bit. Otherwise, they're going to get bored. They're going to resent coming in, and it's not going to be so effective. There is some evidence supporting play therapy in its various iterations, but overall, we should know that the evidence to support its effectiveness is certainly less so than CBT. Now, how can we make evidence-based practice more fun and engaging? And that is really the question that brings us to GB-CBT and the rest of the topic for this presentation. And this is a question that my colleague and co-developer Craig Springer and I had asked ourselves when we were doing this work in a child abuse specialty department at North Beth Israel Medical Center. When we were doing that work, we were seeing families that were encountering horrific sexual abuse for families that were in terrible turmoil, parents that might be facing jail time for abusing their kids, people enduring a lot of financial hardships and a lot of disruption. So it was a tough scene and very distressing scene for the people that we were working with. And to ask folks who are dealing with this level of distress to come into therapy and to be doing it weekly, and maybe sometimes twice a week, was quite a big request. And we found that we really need to come up with more engaging ways and techniques to get people to come in, to stay in, and to engage with the treatment. So we had, through research and other areas, and my colleague Craig Springer's previous research on social skills and ADHD and the use of structured therapeutic games, we began to develop and formulate a curriculum that first started as a group therapy model, then we evolved to an individual therapy model. And we found that by integrating structured therapeutic play techniques with traditional CBT components, the components that I had elicited earlier in a couple slides ago, when we had that integration, we found that we had much greater engagement from these parents and from these kids, despite the fact that they were coming in having to talk about these horrible things. And then we found that once we were successful working with this population, in subsequent years, as Craig and I and others that we've trained and worked with have moved on and brought this model to other locations and worked with other populations, we found that this fundamental approach, this GB-CBT approach, is effectively applied to other disorders as well, including anxiety and disruptive behavior disorders like ODD, ADHD, and more. So this slide here essentially shows how there's an integration in GB-CBT, or game-based CBT, between cognitive behavioral therapy and structured play therapy. So by integration, we're taking those two parts together. And as was mentioned at the very beginning, this is also a transdiagnostic approach, meaning that you can take this approach and you can apply its fundamentals to a whole wide variety of diagnoses. And it's not a model that is only pigeonholed for child sexual abuse or trauma, but quite broadly beyond that. Game-based CBT has 4 what we call foundational principles. First is that it is data-driven, meaning that data is collected before, during, and after treatment. We are advocates of getting baseline measures, doing measures commonly used in the field, such as the Child Behavior Checklist, or the CDI, which is the Child Depression Inventory, or the Beck Youth Inventories that assess anxiety and anger management difficulties. So collecting data helps to guide what work we're going to do, what types of things we want to really advocate for and emphasize in therapy. Also, as part of being data-driven, game-based CBT has been subjected to evidence-based research, and it in itself is all based on very well-studied and used techniques and approaches like positive reinforcement, token economies, selective attention, exposure therapy. These are all things that have been thoroughly studied in the field for a variety of different disorders and difficulties. GB-CBT is also directive and structured, meaning each session has a particular agenda. There's a prescribed structure length, and there are specific games and role plays that we're planning out and doing. The clinician is responsible for kind of coming up with the game plan, and oftentimes in the individual model we'll map out a number of sessions in advance, and we'll know, okay, session 1 we're going to be doing rapport building, session 2 we're going to be working on personal space and boundaries, session 2 we're going to be doing emotional expression skills. So you can even game out or map out what you're going to be doing in advance. This is something that we really we really encourage clinicians to do. Making therapy fun and engaging is perhaps the most important and unique aspect of GB-CBT. We hope, and what we find through our clinical work, that the games are really effective in eliciting positive response from children and parents. They are effective in getting kids interested and motivated in the therapy. Also, we find that the games reduce the defenses that people often have. When you go to therapy, oftentimes, especially if there's a stigma attached to it in your culture and your family, you're not so open to talking about your issues and your problems, especially if it's something like sexual abuse and you have to talk about, the time someone touched you in your private parts. So these games really do help in reducing those defenses, reducing that anxiety, and helping people move past their guardedness in therapy. And lastly, experiential learning. We find that children learn best by doing, and that's also true of adults. And what we hope those games provide is multiple opportunities for children and caregivers and clinicians, in fact, to practice and utilize the skills that we are hoping they are learning in therapy. Here are the different components of game-based CBT. So structured therapeutic games, as mentioned before. So structured therapeutic games are the key feature of game-based CBT. It's what makes it what most makes it a unique model. So I'm going to discuss that first. So what are STGs? So STGs, or structured therapeutic games, are original games. These are not games like playing Candyland or Sorry or Uno. Those are certainly games, and those are games that therapists do in therapy, and it's an aspect of play therapy, playing with board games in therapy. However, the games that we're talking about in game-based CBT are original therapeutic games, and they are developed or designed with consideration of the child's developmental age, meaning that the games, you would be playing with a 5-year-old are not the same games you're going to be doing with a 11-year-old or 12-year-old, because the older kid might find those games kind of cheesy or boring, and the younger kid won't get the older games. These structured therapeutic games have been designed and inspired by different games that are out there that are probably familiar to people. Games like Taboo, or various card games, games like charades, games like Pictionary, races, and some game concepts are entirely unfamiliar, that would be entirely unfamiliar to the client, like the musical Pirates of Mohiki, which involves an elaborate front story and role-playing, and this game Feeling Most Freddy, which is also one in which there's, clinicians role-playing certain actions in different situations, things that are entirely unique and unfamiliar to the client. STGs that we're talking about here vary depending on whether or not they're team-based or individual-based. Sometimes we like to emphasize healthy competition. So, for example, in group therapy, kids are competing with each other to do well. So we have token economies and point systems that really enhance the motivation. Then other games are cooperative, so there's turn-taking involved, communication, and there's no real winners or losers or first place, second place, third place. Everyone's just trying to play together to finish successfully. And one important thing is that clinicians participate along with the clients and use what we call strategic self-disclosure, which is the process by which clinicians tell the clients a little bit about themselves in order to show that they're, accessible and relatable human beings, which is also thought to help reduce defenses and barriers between clinicians and clients. Psychoeducation, as I had mentioned earlier, is very important in CBT, and as so in GB-CBT. And so every session we provide a little bit of education about whatever that behavioral skill is that we're trying to teach, be it an anger management skill or relaxation technique, or something specific to the disorder that the child's encountering. We try to do that didactically through asking questions and answering questions. And then we also play games that will further reinforce the education. We do skill skits, what we call skill skits, what the rest of the world are known as role plays. And these are just skits that we use to demonstrate the different skills. So, for example, if there's a anger management skill we're trying to learn, like called the bear hug, which is a deep breathing technique where we teach the kids that whenever they're really angry, they can take 3 deep breaths. They give themselves a big hug. They take 3 deep breaths in through the nose, out through the mouth. And then we do a skill skit where we practice getting really angry and then using the bear hug to calm down. That's an example of a skill skit that further reinforces the learning and also provides multiple opportunities to practice the skill. So in group therapy, we'll have multiple pairs of kids come up to the front and practice the different skills we're trying to teach. Session structure. So every session has particular behavioral expectations, and this will create the foundation of the different token economies or reward systems that we use in game-based CBT. And in elementary school age kids, you have these 3 rules, which I call the golden rules, the 3 golden rules of behavior management, which are follow directions, control your body, and be polite. Any behavioral infraction can fall into one of those 3 buckets. So if you're not doing what you're supposed to do, you're not following directions. If you're not sitting where you need to be sitting, you're not controlling your body. If you're being rude and nasty, you're not being polite. So we consistently bring the kids back to these behavioral expectations, and we're going to tie them to rewards, as you're going to see in a bit. So token economies, these are a form of positive reinforcement. We have in different versions of this GB-CBT model, be it group or individual, we have what's called fixed interval token economies, and we also have variable ratio token economies, and I'm going to talk about that in a second and explain the difference. So a fixed interval token economy, this particular slide has a diagram, is a picture of the STAR Awards chart. This is a chart that we use in GB-CBT in the individual model and family model. So you'll see that the 3 golden rules are up there: follow directions, control your body, be polite. And what we do is we expect that the children are going to be sticking to those. If they're able to follow each of those rules, they get a star for each one. If they get all 3 stars, then they get a prize from the prize box. So it's a fixed interval, meaning at the end of the session, they are assessed on those particular rules, and if they're able to follow those rules, they earn their prize. Another area of motivation is the variable ratio token economy. So we have super checks in the individual model. In the group model, we have what's called super bucks, where we simply use like Monopoly play money. In the individual and family model, we have super checks. Checks are just simply check marks on a piece of paper. I have on this slide a sample copy of the one that we use in the game-based CBT model. Every time we see a kid doing a really good job following those 3 rules, they could get a super check. Every time they do a really good job playing the games, they get super checks. They get multiple super checks. So if they do excellent in an emotional expression skill game, they might get 5 super checks in one shot. If they get all 20 of their super checks, then at the end of the session, they get to choose an activity or a game or something to play. They get what we call free play time. So they're earning a privilege at the end of the session, and this adds to motivation. First, it turns the whole session into a game because the kids are working hard to get their stars and get their super checks. It also helps motivate them because they're competitive and they're motivated to get their prizes and their privileges. And furthermore, it demonstrates to parents who are usually or typically involved in part of, if not all of these sessions, how to use positive label praise, how to catch your kid being good, and how to use token economies effectively in order to elicit very positive behavior from your children. Game-based CBT modalities. So there are 2 modalities. There's the group modality, and there's the individual and what we call conjoint family therapy modality. The group therapy that we do is a 12-session curriculum. It's a manualized curriculum, meaning all 12 sessions are mapped out. There's a fixed sequence of skills, and usually we have between anywhere is like smallest group being 3. You have to have 3 kids to have a group, and then the largest we've done groups as large as 18 kids. And these groups have been done for hour-and-a-half long sessions. They've also been done in 45-minute sessions, so it varies depending on that. And there's typically a 1 to 4 staff to child ratio in these groups. We also have a caregiver group component to this treatment. We also have this individual and conjoint family therapy model, and in this it's what we call a modular curriculum, meaning that there isn't a fixed number of sessions. The session number and the skills and the games and the modules that you're using depend really on the needs of the child and the family. So we're tailoring the treatment plan to the difficulties and the needs that are presenting. And in this model, what we typically done, and we've done it in 45-minute versions, and we've done it in hour-and-a-half versions. In this model, we typically have a meeting at the beginning of the session between the clinician and the parents, where we talk about the week, check in, we review the skills that we want to to reinforce, and we talk about the plan for that session. Then we have the child enter, and either it's time alone with the clinician and the child or conjointly between the child, the caregiver, and the clinician, in which we play the structured therapeutic games and we review different skills. And then we assess whether or not the child has earned their free playtime at the end, and then we give the free playtime followed by the stars and the prizes if the child has met their behavioral expectations successfully. So that's a typical rundown of how the game-based CBT individual and conjoint family therapy model works. So game-based CBT has two broad interventional components. No matter, again, it's a transdiagnostic approach. So no matter what the diagnosis, no matter what the disorder, you're going to be doing at least the front part of the game-based CBT model, which is a focus on social and emotional skills, social and emotional learning skills. So that is learning, first of all, developing rapport, because if you don't have rapport, you don't have a good therapeutic relationship, you're not making any progress. Secondly, what you're doing is developing emotional expression skills and emotional regulation skills, coping skills, social problem solving skills. These all go in this social emotional learning, or SEL, category. And then upon that foundation, we move into the disorder-specific skills. So that now this is where we transition depending on the specificity of your child's difficulties. If your child's presenting with child sexual abuse and trauma, we're going to be doing game-based CBT modules from that aspect of the curriculum. If your child's struggling with anxiety disorders, with an anxiety disorder, they're going to be doing exposure therapy activities. They're going to be doing relapse prevention activities, whereas a child who has ODD or ADHD may not be doing those exposure therapy modules. So we tailor the second part of the intervention specific to the needs of the child. And again, this is for the individual and conjoint child family therapy. In the group therapies, you would be having children would be recruited for the groups, and they already know, you would have an anxiety disorder group. You wouldn't mix kids who are, with anxiety who have not been abused in a group that has kids who have been abused. You would really have it parsed out already, and then you would have mapped out your curriculum if you're doing group therapy based on the specific disorder needs of that population. And here's just a rundown of the different SEL skills that we do in game-based CBT, and these are things that are very tried and true topics of conversation and emphasis in CBT for the whole gamut of child and adolescent behavioral and mental health disorders. And in disorder-specific modules, here are some listings of those that can be helpful. And again, we're not saying that all of these modules or all these topics are touched on. We really advocate for tailoring the approach for the specific needs of the clients who are presenting. Okay, so this brings us to the game-based CBT sample section. The first game that I want to talk about here is the rapport building example, getting to know you cards. So getting to know you cards is a card game where each card has two questions on it, a 1-point question and a 2-point question. The 1-pointer is a little superficial, simple to answer, kind of like, what's your favorite color, or what's something that makes you feel happy. Whereas the 2-pointers are more challenging and ask the participant to go deeper. So there might be a question like, what was the saddest day of your life, or what do you want out of therapy? And keep in mind that clinicians are participating in these games for a reason, because it makes the clinician feel and seem more accessible and relatable if they are actually playing the game. So when you get a card like, what's the saddest day of your life, you might say something that we don't want you to say something as a clinician that's going to overwhelm the client, like, something like the time I was sexually assaulted in this horrible way. We would say something from our own personal life that's true, but it's manageable, something that the kids or the family can handle. Like, maybe the saddest day of your life was the time that your grandmother passed away because you loved her very much and you're very close to her. So that would be a legitimate thing that someone might experience, and everyone understands it, but it's not so overwhelming to the child or the people playing it where they would feel like uncomfortable that their therapist is disclosing this kind of stuff. And you would try to turn it around, like, they had a very long life and I was very happy for them. So you wouldn't want to leave them hanging in this kind of way where they would feel overwhelmed by the pain and by the difficulty of it. Getting to know you cards are a great icebreaker, and they really help getting people into it right away. Plenty of times we have kids that are super guarded, and they're like, come on, what are you kidding me? I don't want to come see you. You stink. You're a dork. Why do I have to be here? And they play this game, and it pulls it right out of them. They start talking because that's the game, and they don't see it anymore as therapy or as like a pain in the neck. They just see it as a fun thing because kids like to play games. And so this kind of brings it out of them. This is one of our best games, I think. Emotional expression skills examples, feelings fast. So this is a game that kind of combines elements from Pictionary and Charades and Taboo. And the way this game is played is that each participant gets a turn going, and you get a stack of feelings cards. In this, the feelings card stack, each card has a different feeling on it: happy, mad, sad, angry, surprised, whatever. And what your task is as the player is to get the other players to guess what's on your card, and you have to express something in a certain particular way. So there is a mode of expression card that you pick, and in those mode of expression cards, you may either pick a draw or a talk or an act out. So let's say you picked a card that says draw. Now you have 2 minutes to get the other players to guess as many of the feelings cards that you have as possible by only drawing. So you have a piece of paper, or if you're doing this in group and you have a big easel or a whiteboard, you could just start drawing faces or drawing scenarios, trying to get everyone to guess as many. And you get points based on how many cards you are able to get the other players to guess. And you play multiple rounds of this, and by doing this, the players, the children, the parents, clinicians, everyone's practicing. You're enhancing your emotional vocabulary. You're building up your ability to express your emotions, and you're just becoming more comfortable talking about emotions in general. So this is a game that's fun. You can play multiple rounds of it. You can play a whole session just doing this, and then it's a lot of fun. Coping skills example. So the thought awareness game. One of the things that we like to do in CBT is teach kids that thoughts are sometimes positive, sometimes negative, and it's your choice whether or not you want to believe them and whether or not you want to believe if they're true. And we present what's called the cognitive triangle, which is, we didn't invent this. This is a classic cognitive behavioral therapy technique. It's just a triangle, and it has thoughts, feelings, and behaviors, and we show how each of them are connected, and how you, in any given situation, you can look at it in a positive way or a negative way. And if you look at it in a negative way, it's going to create negative feelings, and it's going to lead to negative behaviors and negative outcomes. And then conversely, if you look at it in a positive way, it'll lead to positive feelings, behaviors, and outcomes. So we have this game, this thought awareness game, where we have a list of, say, 30 self-talk statements. Some of these statements might be, every time something goes wrong, it's always my fault. Or another self-talk statement might be, I believe that I can do it, or I believe I have confidence in my ability to be successful. And what we want to do in this game, and this is for kids that are like in elementary school, kids that can read at least, they race through this, and they have to put a plus for a positive self-talk statement and a negative for a negative self-talk statement. And we race through it, and we have a first place, second place, third place, etc. Finishing based on how fast they've completed it. Then the clinicians can review it to make sure it's accurate. And also, this is a great tool for going through, different self-talk statements and reviewing, hey, why did you think that was a negative self-talk statement? If you say it's always my fault, is it really true that it's always your fault? Can you find counterexamples? So the game itself, in processing the game, opens the door to conversation about how to deal with your thoughts in a more effective way and in a more flexible way. Relaxation training example, the relaxation competition. This is kind of an oxymoron, right? Relaxation and competition don't sound like they should go together, but it's actually a very effective game. And this was inspired rather by the old staring contest game, if you've ever played that as a kid. In the staring contest, you'd have two kids that would be sitting there, staring at each other, and the first kid to blink would be the loser. In this game, we play this in group as well as in individual and family therapy. And what we do is we'll have the players sit in a comfortable position, and we ask them to take a few deep breaths so that they're calm and relaxed. And then we will take turns rolling a die or a dice, and whatever number we get, we're going to multiply that by 10 seconds. So let's say you roll the die and you get a 5. That means 5 times 10 is 50 seconds. So for 50 seconds, we're asking you to be perfectly calm and still and take relaxing breaths despite what's going on around you. And then we play multiple rounds. And in the first round, we might just be silent while we're doing that. Let's see if they can sit still for 50 seconds. And if every player that is able to do that will get a point. But then the clinicians can increasingly up the ante and make things more intense. So if you're trying to teach the kids to tolerate a lot of distress and frustration and aggravation around them, we're trying to teach them to be the eye of the storm, the calm center of the storm, despite what's swirling around them. Well, we're practicing that. We're practicing that by having them be calm, and while they're doing their relaxation exercise, the clinicians will sometimes get into arguments with each other, just like pretend arguments, or they will talk loudly, or they'll make silly comments, and the goal is really to break the child's concentration, or break the participants' concentration, so that they laugh and they fall down, or they get freaked out or something like that. We're trying to train them to resist that urge. So we're not trying to inoculate them against that stress by doing this. And the relaxation competition is really effective. I mean, I've seen this with kids who have like severe ADHD. They're bouncing off the wall. They can't sit still. But then when they do this game, they're actually focused. And by playing this game and practicing their coping skills, this is really a nifty way to get them to reinforce the learning. Whereas otherwise, if you're just lecturing them and just telling them to do it, a kid with ADHD who's bouncing off the wall is going to say, no, I'm not doing that. That's boring. That's dumb. But if you're doing it in the game, now you got them. Now they're going to do it. Not all the time, but certainly more so. And when you slap super checks and super bucks and other fun things on it to make it more game-like and make it more competitive and fun, you're going to get more engagement. So the relaxation competition is really fun. I also have an alternative version of this called the mindfulness competition, which is a similar idea. Each round, instead of just listening to either silence or like chaos in the room, what we're doing is we're focusing in the present moment on particular stimuli. So it might be listening to how many sounds we can hear in the time allotted, or how many things that we can notice with our sight, or how many breaths we take, or noticing the thoughts that pass through our mind. And then you actually get points for noticing things. So if you come out of that particular round as the player and you notice like 5 or 6 things that you heard around you, either in the room or outside of the room, well, you were being mindful. You were paying attention to the present moment, which is the definition of mindfulness. And as a result, you're going to get points for that. So we're incentivizing the positive. We're incentivizing the use of those skills within the context of the game. So let's move on to the next game example. This is a psychoeducation example called Knowledge by Letter. This was inspired by the game Categories. So if you remember this game, what you have is the challenge is coming up with different responses to particular items that begin with a certain letter. So with this game, I'm going to give you an example from the child sexual abuse curriculum. So with this game, you would play this game and you'd have a list of, say, 15 items, and the items will be varying in terms of what it is, from anything like how does a kid feel when they are sexually abused, or what's a sexual abuse action, or what part of the body can be targeted by sexual abuse, and then you need to come up with responses beginning with a particular letter. So before the round starts, what we do is the clinician will pick a letter at random. So let's say that the letter is B. Then the players, we need to race through this sheet and come up with as many responses beginning with B, and they get points for coming up with more responses. So for example, if the question is, how does a child feel when they are sexually abused, a B word might be betrayed. So you'd get a point for that. And that's how this game works. We also have versions of this that can be applied for different disorders, and it creates a funny conversation too, and it opens up dialogue about the different topics that we're learning. Say, for example, with anxiety, there's a list of different items that bring up conversations or topics related to anxiety disorders. The same could be said for tics and OCD, what have you. We can apply this approach to the different disorders, and it's really helpful because it gets the people, to laugh a little bit, also to engage in conversation about their difficulties. Parent training. So this parent training example, what if my child did game? So with this game, it's kind of like Family Feud, where you're trying to assess particular responses to a particular question, and certain responses are going to get more votes or more points than others. And this is a game that we play in group therapy for parents who are, learning and getting parent training. What we would do is we throw out different situations, like what could you do? What if your child did XYZ? So an example would be, what if my child pulled the fire alarm at school and it was a false alarm? Now all the players, all the parents in the group will write down how they would respond, anonymously write it down, and then the group clinician or the group leader will collect all the responses, read through them, and everybody votes on which response they think is the best. And usually there's some comical ones, like someone might say, I'm going to beat the crap out of my kid, or I'm going to send the kid to Canada, or something crazy like that. It makes people laugh, and they joke around about what they would do in that situation. But usually there's a consensus around a really smart strategy, like if my kid pulled the fire alarm, I'll sit down and ask what was going through your mind, how can I help you if you're having difficulty, whatever it is, some very positive pro-social response that would end up getting most of the votes. And then whoever's response won the most votes, that person will get the points for that round. And you play multiple rounds with multiple scenarios, and by doing that, you're actually accessing the knowledge and the expertise of the other parents in that room, and everyone kind of pools together their knowledge and their experience, and they kind of work together towards finding solutions to various difficult and challenging situations with kids. Catch the Tic. This is a game that is sort of building upon a technique that Douglas Woods speaks about. He's one of the co-founders of CBT, or the Comprehensive Behavioral Intervention for Tics and Tourette Syndrome. This is Catch the Tic is a tic awareness training game where we have the kid and the clinician and the caregiver will play a regular game, like a board game such as Candyland. And during the board game, the object or the challenge for the child dealing with tics is to catch their tic before it emerges. They will typically have this premonitory urge where they feel it coming on, and if they feel it and they catch it, they're going to raise their finger in the air. And if they're able to raise their finger in the air and then do their competing response, which prevents them from actually engaging in a tic, then they get a point. However, if they engage in the tic before they have a chance to catch it, and the clinician or the caregiver or whoever the other players are sees them doing the tic, then the other players get the point. So this is like a game within a game. So while you're playing a fun board game like Candyland or Uno, you're watching each other, and if the kid's engaging in the tic, then that person gets a point. You could also make it more relatable by having the other players, like the caregiver or the clinician, deliberately engage in the same tic, so that the player can see it, how it would look if someone else is doing it, and help increase self-awareness of the tic. So this game can be played at home as well, so oftentimes we'll give that as homework. So go home, play games with your kid, and you play Catch the Tic. And lots of times kids do really well with this because you're creating an incentive for them to really focus on catching that tic before and developing that tic awareness, which is really important, especially with younger kids. In order for them to overcome that tic, they've got to become aware of it so that they can do their competing response. Okay, so moving on, we have our last example here, which is an exposure therapy example. It's called Unlock the Path, and Unlock the Path is a board game, and has multiple levels in this board game. Each level on the board has a particular task assigned to it, and it's correlated to what's basically called a fear hierarchy or fear ladder that you develop with the client beforehand. And this is anxiety-provoking situations, persons, places, and things, and situations that cause anxiety at different levels of intensity. So low-level anxiety, moderate-level anxiety, high-level anxiety, and they're all arranged in this board. And within each level, there are different tasks. So one task might be to practice a coping skill. One task might be do some silly office trick like crumble a piece of paper and throw it in the garbage can. But another task might be do a particular exposure. So an example of in-session exposure might be if you have emetophobia, which is fear of vomiting or throwing up. We see these cases. Your task might be watching YouTube videos of people throwing up. that might be on the list somewhere. So these different tasks that are built into the game that you kind of work out beforehand as the clinician, you tailor and customize the board for the needs of that client. And then as the client works their way through this board game and completes tasks, they're moving up levels, they're unlocking paths to the next level. And through the process of going through it, they are overcoming their anxiety through the exposure therapy procedure. They're gradually becoming more desensitized to the anxiety-provoking stimuli, and thus, successfully making their way through treatment. And they're all doing this through the context of an actual game, which is what makes it, fun, less intimidating, more engaging, and easier to get through. So those are our game examples. Just briefly on empirical research, the GB-CBT model has been studied for group therapy and individual therapy for children experiencing child abuse and trauma, and has shown effectiveness for improving a number of different symptoms, including internalizing symptoms such as depression and anxiety, as well as externalizing symptoms such as aggression and oppositional behavior. It has also been found to be effective in reducing sexually inappropriate behavior in child sexual abuse populations, increasing knowledge of abuse and personal safety. And we have also found that 3 months after and even 6 months after treatment has ended, that the majority of the treatment has sustained, which is very good to see and that we're happy with. And since this work has been done, we're in the process of applying the GB-CBT model to other populations and to studying its effectiveness with other populations. So there's still much more work to be done, but we're excited to bring it to other locations and other practitioners and to other populations. So with that, I'd like to open it up to questions and answers and provide answers, hopefully. I also like to alert the at-home audience to a list of publications that we have, as well as the Game-Based CBT Textbook. Now this is the book that we wrote for child sexual abuse, but keep in mind that the front half of the curriculum is all social and emotional learning. So oftentimes I'll have people say, well, my kid wasn't sexually abused, why would I need, or why would I look into this? Or if a practitioner doesn't work with child sexual abuse, it's still going to be very helpful for you because the structure and a ton of the games and activities that are contained within the book are applicable to these other diagnoses and disorders. So with that, I'll open it up to questions.
Okay, thank you very much. And I'm going to start right away because we have multiple questions, and I'm sure this is a question you get often. Multiple questions on where do you get the games? So I'm going to, a couple of them I can combine, but basically, does a child, who is in session with you, does a child take home any of the games, or are they all reserved for the office?
No, so these are games, all the games are accessible currently through this book. So you could purchase this book on Amazon. You could get it from the Springer Publishing Company. What we have is all of the stuff can be printed out or photocopied. It's in the back. So for example, that Getting to Know You card game, it's a card game that those cards you can print out and cut them up and then you have it. And what we do in therapy is that we'll make all these game props and then we'll give them often to the families to take home to practice for therapy homework at home. We also have a link inside the book that you can go to the access on the website of the publisher that allows you to download PDF versions of all these games so that you can just print them out at your leisure at home, and then you can have like a mass amount of them. And
Okay.
you can keep them, yeah.
That answers pretty much, I think, all of the game questions, but there was one that was slightly different that had to do with whether or not the games in your office are computerized. So are they all literally, the game you mentioned that was Unlock the Path, you said had multiple layers. Is that a type of computerized game?
No, that's a board game again where there's the sheet of it that you print out. I just want to say a couple things that you're mentioning that are coming to mind. So a lot of the games that we're using for anxiety and disruptive behavior disorders, those are not in this particular book because we're developing them right now. We have an unpublished manuscript and we're in the process of publishing that in a book, hopefully in the next year or so. But the current book covers social emotional learning and that covers a lot of difficulties that are out there, and all those games, the paper and pencil version of them are in those, are in the back of that book and easily accessible. However, the electronic game idea, the video game idea, is one that we are actually working on. We currently have a grant that has been funded through the NYU Child Study Center to develop a CBT video game app that could be used in session on smartphones, tablets, and laptops. And essentially what it is doing is it's taking the games that we have right now in the paper and pencil version of it and putting it into a digital format, which is even more accessible and interesting to kids. So that's really the next frontier. So we have multiple aspects of this GB-CBT project that we're working on, and the electronic version of it is one that's in the works. So I'm glad you mentioned that.
Okay, so individuals then could go to the book or go online to the publisher and be able to print out pretty much all of the games you mentioned tonight.
Yes.
Is that correct? Okay.
Well, not all the, so the catch the tick game, I mean, some of these games there's no props for it. Yeah. It's just like a game idea or a technique, and the book and the catch the tick game is not in that book because this is a book for child sexual abuse. But many of the other games that are listed in this game examples are actually in the book. So getting to know you cards, the feeling fast, the thoughts awareness game, the knowledge by letter, relaxation competition, unlock the path. Those games are all in there in that book.
Excellent. Okay. So have another question about games that's slightly different. So for games with incentives to limit behaviors that are involuntary, such as tics or ADHD behaviors, for example, is there research that the temporary ability of students to limit their behavior becomes more permanent with practice?
Is there research showing that by doing this kind of work?
Yes, repetitively, that it will limit their behavior, so that it will temporarily, let me go back and look at the question again. Is there research that the temporary ability of students to limit their behavior when they're doing a game can become more permanent with continually practicing the game?
So that's a good empirical question. The closest thing I've got to that is the research that we've done has looked at like longer term outcomes, like pre-post treatment and a 3-month or 6-month follow-up, and we found that certain disruptive behaviors are reduced. Now keep in mind though, that was for among population who has experienced abuse and trauma. Many of those kids also had ADHD, but we haven't done any formal studies on the games for ADHD in particular, so I couldn't answer that one empirically. But there's a lot of, what you will see is that there's a lot of directions that we need to continue to go in to further study and understand the model and its effectiveness. So that's a really good question. Okay,
so next question. If it appears that this method for children and teenagers, it appears that this method for children and teenagers, but are games, are they conducted for older adolescents and adults? That's the root of the question.
Right. So right now, this model is really for children and families, and by families I mean parents are playing as parents. So some of these games you could do in therapy, like here and there, and it would be interesting and applicable to parents and adults playing it. But for the most part, this is a model for children and for adolescents. I would say that right now the sweet spot really for this model is for like elementary and then middle school age children, and certainly the book that we wrote is targeting that population. So we're talking about kids starting at age 4 or 5, like the preschool age, and then going up to like 6th grade.
Okay. Have a couple of questions kind of fashioned, not on buying games or figuring out games anymore, but given that we're a TS organization, we have a lot of TS people online. So you made a point, so there's 2 parts to this, but they're really basically all in the same. You made a point about controlling your body and on one of your slides. And the comment is that that can be an intimidating situation for a child with TS. So how does that work in that situation? And then along that same line, there was concern about a child trying to control a tic to get a point in a game. And then in another situation in that same question, or to see someone kind of mimicking a tic. So again, this is coming from our TS community, and I think those are valid concerns among educators and families with a TS child.
All right. So the first part about control your body. So with controlling your body, and say this is really, we haven't done any group therapy for children with tics or Tourette syndrome. All the game-based CBT that has been done to date has been just in the individual model. So we have great latitude to tailor what we're doing. So we modify our expectations for those 3 rules: follow directions, control your body, and be polite for the child. So if I have a kid with a tic disorder who is ticking and he's not controlling, he's not going to lose points or lose out on a prize because of that, because that's not his fault. That's his disorder. Same thing if I have a kid with ADHD who's moving around a lot and fidgeting a lot. As long as it's not blatantly disruptive or directly impeding on things, then they're going to get credit for controlling their body, because I'm assessing them based on the limits of their capabilities. And then to the other, so with the kid with tic, we wouldn't want them to feel pressured or intimidated for this. When we say control your body, we're really talking more about like trying not to hit or throw things. And keep in mind, we also have, I see kids that when they have bad temper tantrums or explosive tempers, they're going to throw, they throw things, they get upset, they hit the window, they hit the wall. So those are really what we're talking about by controlling your body. In more of like a safe and
yeah, very understandable there. So the idea of trying to get in that chase the tic thing.
Catch the tic.
A child trying to control a tic to get a point in a game is something that could be more stressful than the child wants to deal with. And have you encountered any of that in that particular scenario?
I mean, so we're not giving them a point per se for like controlling the tic. We're trying to give them a point they're getting a point for being aware of the tic. So we're really incentivizing the awareness piece.
So the monitory urge then is what you're incentivizing.
Yeah, it's catching the tic is you're catching it because you're aware of it, rather than whether or not. So if you caught it, you put your finger up, but you really couldn't hold it back, and you had to give into the urge. That's fine. You would get a point for that. I think that I didn't adequately describe that particular part of the instruction. Also, I wouldn't necessarily mimic the tic. I wouldn't have the other players intentionally mimic the tic unless I thought it would be helpful to a kid. Sometimes with younger kids, they might want to see like that they're not the only one that might have something that they've got to control, in which case we'll have the parent or the clinician have some kind of thing that they're dealing with in order to feel like they're on like a level playing field. But if that particular angle of it is not helpful, then they don't have to do it. Certainly the most important part is just the tic awareness piece. And this game, I mean, to be fully honest, it's a game that is being used in a somewhat different format, but basically essentially the same game is in CBT, because I got the idea from that.
Okay,
and the CBT is well established.
All right, so we'll move off. Those were very heated questions. We had quite a few of those. So let me get to a question about a child who has a trauma from abuse, specifically about the groups. So how big are these groups? And is it difficult to work with a child that has that type of trauma in a group setting?
So that's a great question. I love doing those groups because of the intensity that you get from it, especially when you develop great group cohesion and you really work everybody through the curriculum and the different games and get to a point where people are disclosing and processing what happened to them. It's just tremendously healing, and very powerful to see. In terms of like the numbers in the group, the largest group I've ever been a part of was like 18 kids, and we had maybe like 4 or 5 clinicians in the room. That's so rare, very rare, and usually the groups are like between 6 and 8 children and maybe like 2, maybe 3 clinicians. So there are a whole lot of things to keep in mind when doing those groups. In fact, I provide supervision and consultation to different agencies that are doing work in this area. It does require a lot of training and a lot of thought. So I wouldn't just haphazardly suggest people go into child abuse groups, start running child abuse groups without a lot of training.
Oh, I would say so, yeah. So how do families find you? Are they typically, or find this program, are they typically referred by a pediatrician, or so how does that work?
Well, so game-based CBT is a model that's being used at various locations, and the people doing it are people that you know, have been trained by Craig Springer and myself and our other colleagues. And so how they find it, I mean, the best way for our current audience, for people going to the website, I would say to reach out to me via email to I have right now on the screen at my NYU account. Email me if you have specific questions, and I'll be able to kind of point you in the right direction. Right now, there's a web page for the book that the publisher has, but there's no game-based CBT organization. There's no game-based CBT website. It's just a model and an approach that people are starting to use, and is catching more attention and interest, especially since the book came out about 2 years ago, and we're hoping to continue to harness that. We're also looking for people who want to learn how to do it, and who want to add to the literature, because we can't study all the things that need to be studied related to game-based CBT, and we need help doing that. We need help expanding the curriculum. So we're open to people in the field professionally who want to reach out and to work with us, or to at least communicate their ideas. So I'd say, you know, the best thing to do right now is to send me an email if you have further interest.
Okay, thank you. When you've talked about the groups, you've talked about, so I have 2 questions that are kind of the same thing about the groups. In a 2-parent family, you mentioned a caregiver. Is that typically both parents, or how do you determine that? And the next half of that is, do you do any work with siblings, or is it just the parents, the caregiver in this case, and the child?
Yeah, good question. I mean, in the individual model, it depends on the family. So regarding what caregivers are present, the people who, you know, at least one caregiver is what we ask. It's not always reasonable to ask for both to be present because of scheduling, work, and other things. So as long as one person's there in a 2-parent household and can communicate to the other parent what's going on, and then occasionally we can have phone calls to catch the other person up, or occasionally have the other parent come in. But as long as one is available, that's all that really matters. And in terms of siblings, we've done sibling sessions as well. In particular, if there are kids that are dealing with the same disorder, or if there's kids that are dealing with you know, dysfunction and conflict between each other, they could definitely go through the game-based CBT curriculum, in particular the social emotional learning modules, and get a whole lot out of it.
Okay. Going back to the group you mentioned that had something like 18 people in that, what were the range of ages inside of that group?
Okay, so that's a good question. And the groups are in a narrow age band, so we usually do groups like from kids between the ages of 5 and 7, and then we'll group kids between 8 and 10, or 8 and 11, and then kids from 11 to 13, and then, you know, 14 to 18. So we developmentally divide it, because you're not going to, nor should you have like a 13-year-old in there with a 5-year-old. It's just not appropriate. It's not, the material is going to be different, the understanding, the cognitive abilities are going to be different. So with those kids, those 18 kids might have been, and listen, I don't want to overplay it. This was maybe one time that we had that many kids. Usually it's lower than that. But I think that was a group of kids between the ages of 5 and 7 in a child sexual abuse department, where your biggest age range, or the most populous age range, is in the lower elementary school age kids. The reason being that younger kids are the most vulnerable to being sexually abused. And then also those were the types of referrals we were getting. So that's why they were so populous.
Okay. All right. We've gone over, but we still have quite a lot of audience left. So I've got one more question for you.
Sure.
Okay. And then we'll wrap it up after that. This comes back to a game question. So is there any game specifically recommended for children with recent trauma? And this is coming from a clinician. This individual says that they're working with a child who saw his father die due to an assault, and was wondering if there would be more appropriate recommended game for a case like this. Can you give any guidance in that direction?
Yeah, I mean, I would work them through, if you just got this case, I would work them through a number of sessions before I jumped into that, unless there was some urgent emergency why you need to go right into that. The idea behind game-based CBT being that we build upon each thing like a building block. I would start with like those rapport building games like Getting to Know You cards, and there's other ones. And then I would do some emotional expression games just to get the child to feel more comfortable interacting with you. And then after a couple sessions of doing that, maybe do a coping skill game or two. And then you move into what we call basic disclosure games, which are designed to elicit discussion of the trauma in a nonverbal way that's less threatening. And then from there you get into a game like Unlock the Path, where you're asking and you're supporting them basically through, verbally and through drawing and through other means, processing and discussing the trauma that they've gone through. But something that's that intense is definitely going to need, a number of sessions. And I would just kind of map out a game plan and go through it methodically. I wouldn't start with if Unlock the Path is the real go-to game that you want to do in a situation like that, you wouldn't do that in session one. You would need, at least 5 or 6 sessions before you get there.
Okay. And I guess a lot, too, would depend on the age of the child and,
Yeah, absolutely. Yeah. And also the training and experience of the clinician, too, and how comfortable they feel. Like, I don't want to say pick up these games and run with it if you're not getting the effective supervision, if you're not fully trained in a particular condition or disorder. You really need to get that additional support rather than just taking the games and running with it. So I want to just put that caveat out there. And if people are interested and they have questions specific like that, I'd be happy to help with pointing you in the right direction for where you might be able to get that supervision and guidance.
Okay. With that, I'm going to end the Q&A portion of tonight's presentation. Thank you very much. There was a lot of great information there. I'm going to turn this back to Kelly for her to do a wrap-up.
Thank you for joining us on our webinar, Game-Based Cognitive Behavioral Therapy. There is an exit survey which we need everyone attending to fill out. The webinar blog is now open and available for the next 7 days on the NJCTS website for additional questions that were not covered in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted to the site. Our next presentation, Psychological and Educational Assessments, presented by Dr. Lisa Ahern, is scheduled for September 13th, 2017. This ends tonight's webinar. Thank you, Dr. Misurell, for your presentation, and thank you, everyone, for attending. Good night.